Okay. Welcome back to this session on mechanical ventilation modules. Today, I'm going to talk about disease-specific ventilation strategies, particularly focusing on ARDS and bronchial asthma. Over the last couple of sessions of mechanical ventilation, how to these children. In this particular talk, I'm going to be focusing on how to set up a ventilator, what are the initial settings for normal ventilation, and later on we are going to deal with ARDS and bronchial asthma in case if they get ventilated. So this is what I'm going to deal with: normal lung mechanics to begin with, then followed by ARDS or acute hypoxemic respiratory failure, and then severe airway obstruction, that is bronchial asthma, in case these children require mechanical ventilation. So, so this is again an overview about ventilation and ventilators. We have moved far from the iron lung ventilators, from negative ventilator to positive ventilator, and it's become a necessity in the ICU. Before connecting to any ventilation, even in the last sessions also, we have multiple times have told you that we need to understand, we should have a basic knowledge and understand the technical terminologies of mechanical ventilation, and also for what type of lung you are ventilating these children. They could have normal lung, they could have abnormal lung. So what are the benefits of mechanical ventilation? So it reduces the work of breathing. It prevents and also eliminates the respiratory muscle fatigue. Hypoxemia reduces. It improves the alveolar ventilation and avoids significant hypercapnia and respiratory acidosis. Also, it takes care of atelectasis and collapsed lung segments. All this indirectly or directly can also improve the cardiac output of this patient. So these are some of the benefits of the mechanical ventilation. Lights are not moving. Okay. So before you ventilate a patient, you should also know some of the drawbacks of mechanical ventilation. So we know very well know that ventilation also can cause something like ventilation-induced lung injury, which is associated with mortality in ARDS and very well proven in multiple research and publications. So what is this ventilatory-induced lung injury? It can cause barotrauma because of high pressures. Excessive volume or low volume can happen, and that can lead to volume trauma. And if you give too low volume, that can also leads to atelectatic trauma. Biotrauma because of the oxygen. Some conditions like ARDS where the inflammatory surge or inflammatory cascade is dysregulated. In those children, if you don't ventilate them appropriately, these children can develop biotrauma, and because of the mechanical power or excessive mechanical power or variation, they can develop ergotrauma. So these are the drawbacks. In addition to ventilation lung injury, it can also have hemodynamic instability. And children, if we are ventilated, we have to sedate and analgesia, to give a higher dose. And inappropriate use or overuse of all this can lead to withdrawal and delirium. And nutrition can get affected, in addition to other comorbidity conditions. So one need to understand when we have to ventilate these children, and ventilation is just a support and it is not a cure. So this you have heard even from my last talk. And what are we trying to do in mechanical ventilation? We are going to mimic the normal respiratory physiologies for various pathological conditions. So initial ventilatory settings depends on the goals and the lung mechanics. Okay, so when we are ventilating, it's not just a child with a bronchopneumonia. You can have a child with normal lungs, or sometimes you have a child with heterogeneous lungs pattern like ARDS, and also these disease lungs have got changing dynamics, and that can have very frequently you have to change the ventilating settings as well based on the clinical status. So sometimes you have a combination of both the parenchymal as well as obstructive lung disorder. Something like if a known case of bronchial asthma develops bronchopneumonia or H1 pneumonia, which can progress into ARDS. So they have a combination of two conditions where compliance is affected because of the ARDS lung, and your resistance is also affected because of the obstructive lung pattern. So one needs to understand the pathology of or a pattern of disease lung before you ventilate. So now coming to the main objective of this talk is how to ventilate a child with a normal, abnormal, and as well as abnormal lung. So let's look at the child with normal lung mechanics and gas exchange. So what are the conditions? So we know that if we have a normal lung exchange and gas exchange, do you remember this figure? So we consider the lungs and the airways as a balloon with a straw. So the upper airway is what contributes the resistance, and the lungs as such contributes the compliance. So in a normal lung, as you can see here, so the resistance is good and the compliance is good. Correct. So we don't have to do use very high settings such a children. So this various conditions which can have normal resistance and normal lung. So I'll take you through a scenario. This is a 5-year-old child who is brought with history of fall. On arriving in the ER, so he has respiratory rate of 10. He's into respiratory failure. He's hardly breathing. Irregular breathing is there. Saturation is though maintained. His blood pressure is high. So and heart rate is 70. So this is a child with severe traumatic brain injury with raised ICP, and as a result of this, he's got labored breathing. So this is one of the conditions. The other conditions where you can have normal lungs but require mechanical ventilation are children with shock. Not in the early phase of shock, but in the late phase of shock. So when the respiratory drive is so high, they have metabolic acidosis breathing. The cardiac output can get compromised. So in shock children in the late phases, one can consider mechanical ventilation, where lungs can be absolutely normal. Of course, in children with raised ICP, like the case scenario, a child with trauma or a child with the status epilepticus, they can come with require mechanical ventilation. And also in post-operative, some of these children post-operative care will require mechanical ventilation. Rarely upper airway obstruction, severe upper airway obstruction also can require. In all these conditions, the lungs are normal. But what are the issues? There is a mismatch between the supply and demand. The resistance is normal, the compliance is normal, but there's a mismatch between the supply and demand at the tissue level. And one need to anticipate a difficult airway. It could be physiological or an anatomical difficult airway. So in what goals of the mechanical ventilation in such a patients? If it is shock, so one, you will be ventilating to take care of the oxygen delivery, to improve the oxygen delivery and decreases the work of breathing. In case of neurological cause like status epilepticus or raised ICP, the PPV, that is a positive pressure ventilation, helps in modulating the cerebral vascular reactivity. We can have a tight control of PaO2, that is oxygen, as well as PCO2, which is very, very important. And any variation in this can cause ICP surges. In post-operative and upper airway obstruction, mainly to take care of the airways, to protect the airway and sometimes to control pain. So in these scenarios, we will require PPV, and remember, the lungs will be absolutely normal. So we have to just maintain the adequate gas exchange, and that can be achieved with the age-appropriate ventilatory settings. Okay, so let's move on. Having understood the normal lungs ventilation, we'll move on to a patient with acute hypoxemic respiratory failure, that is ARDS. So this is in ARDS, what happens? You must remember this picture. So again in ARDS, what happens is compliance is affected. So this is a patient where you can see that the lungs are completely wiped out, and the airway, that is the resistance which is offered by the upper airway, is preserved, but the lungs are very, very small. So we say baby lungs or a sponge lung. Okay. So here we are dealing with the child with decreased compliance. Commonest causes pneumonia, bronchopneumonia, going on to ARDS sometimes, and airborne epidemics. So basically the pathophysiology we have to understand, one need to understand before we go on to ventilate this patient. So patients like in ARDS, they'll have high inflammatory surge. As a result, they develop alveolar filling, high proteinaceous pulmonary edema, interstitial and alveolar edema will be bad, and they'll have surfactant dysfunction. So there will be destruction of the alveolar epithelial membrane. All this will result into hypoxemic respiratory failure. The lung compliance will get affected. It can become very much decreased and poor lung compliance. And you'll have small alveolar or the baby lung, which could be collapsed. And as a result of all of this, the dead space is increased. These patients will have hypoxemia. Sometimes in case of extrapulmonary ARDS, the abdominal pressure in obesity or in child with pleural effusion, they can have decreased chest wall compliance as well. So that's a very rare component. But remember, when you are dealing with ARDS, these children will be having severe hypoxemia and the lung compliance is pretty bad. So in such case scenarios, one may have to consider positive pressure ventilation to elevate all the symptoms. So let me take you through this scenario. This is a 2-year-old child who presented with fever and respiratory infection, and he has breathlessness since last 2 days and is irritable. He's been treated outside with some amoxicillin. So on assessment, he is conscious, irritable. He seems to be tachypneic. He's maintaining saturation around 80% in room air. And after connecting to NRBM, it's increased to 100%. So he's tachycardic, and the CFT is prolonged and blood pressure is 80/40. So he has some compensated shock. Blood sugars are maintained, and look at his ABG. ABG has got, this is arterial blood gas. So it has got severe respiratory acidosis along with hypoxemia as well as metabolic acidosis. So we are dealing with a child with respiratory failure and compensated shock. So, and this child has been started with NRBM, IV line has been established, a fluid bolus was given, the liver size and the hemodynamic monitoring was done. But when we got his X-ray, the X-ray, as we can see, it's completely flooded. The X-ray white out lungs. Okay, so is this ARDS? So that's what we are going to. So when we look at the definition of ARDS, that's a PALIC-2 guidelines, which is published in PCCM 2023. So it's got a clear-cut criteria for to diagnose ARDS. So what are those? So in a patient age, you should exclude patient with perinatal lung disease. That's the first criteria. So you should not be including some small babies or a newborn or a premature baby. So you need to exclude this perinatal lung disease first to begin with. And the insult should be within 7 days. Okay. And the origin of edema, that cannot be fully explained by cardiac or a failure or a fluid overload. Coming to the chest imaging, that is a chest X-ray. So it should show new opacities, unilateral or bilateral, consistent with acute pulmonary parenchymal disease, and which are not due to primarily atelectasis or pleural effusion. So it just not some collapse, consolidation or pleural effusion. It should show some new opacities. So unilateral or bilateral. That is with the chest imaging, either by a chest X-ray and or a CT scan. So once when this child fulfills all these criteria, then you need to look at the oxygenation. Suppose if it is invasive mechanical ventilation, it is OI. We have to calculate the OI or a OSI. So what is this OI? OI is oxygenation index. So it is nothing but your MAP, that is mean airway pressure, into FiO2. You must have heard these terminologies when we had a class on basics of mechanical ventilation, isn't it? So MAP into FiO2 divided by PaO2. So once we do this, if it is more than 4 or 5, then this child will fit into ARDS. Suppose in the early stages of ARDS, what we do consider is non-invasive ventilation. So one can still try with NIV, non-invasive ventilation. There we calculate PF ratio. That is PaO2, what you get on the blood gas, divided by the FiO2, how much the FiO2 you're going to set it. So if it is less than 300, then it is ARDS, or SF ratio. SF is what you get on the pulse oximeter. So SF divided by, SpO2 divided by FiO2 if it is less than 250. So remember these numbers. Okay. So once you do this, then we'll move on to the stratification after 4 hours of initial diagnosis. Okay. So that we will deal in the next slide. And suppose if a child has got cyanotic congenital heart disease, rarely you can get a CCHT, something like a TOF. But if the TOF child develops pneumonia and there is an acute deterioration in oxygenation not explained by cardiac disease, then also they will fit into ARDS. And chronic lung diseases, we do see a lot of children with CLDs, prematurity, CLDs coming with RSV. We had a couple of children in the ICU where they had CLD, but they developed pneumonia and ARDS. So those children also can be classified as ARDS once they fulfill all these criteria. So in the index case, that child was a small child within 7 days. All these criteria were fulfilled. So, but we had to calculate the OI and OSI, right? So once you calculate the OI and OSI, After 4 hours of public parts diagnosis, you have to classify them as severe, severe IMV parts or severe NIV parts. So if OI and OSI, if IMV, the last slide we said, if OI is more than 4, OSI is oxygenation saturation index. Instead of your PaO2, you will replace it SaO2. So if OI is more than 4 and it is fulfilling IMV parts, after 4 hours of application, if the OI worsens to more than 16 or OSI worsens more than 12, it becomes severe parts. Likewise, in if a child is getting non-invasive ventilation, after 4 hours, if the PF ratio from 300 drops to less than 100, that child also will fulfill the criteria of severe NIV parts. So you remember this criteria of when do we call mild, moderate, or a severe NIV parts. Okay. So coming to the ventilation strategy, how to do these ventilatory settings, how different it is from the normal ventilatory settings. So remember, whenever we talk about ARDS, we always talk about lung protective strategy. So lung LPV, lung protective ventilatory strategies. So why do we need to remember this? Because on one hand, you need to protect, you are giving protective. On the other hand, you're going to prevent ventilator-induced lung injury. Okay, so lung-related causes, we have discussed that ventilation has got its own drawbacks like villi and other hemodynamic effects. When we are ventilating these children, especially ARDS, one should remember the lung volumes are very, very small. They have got something called baby lungs. Why it is compared to the baby? That's because their tidal volume in normal ventilation, the tidal volume, what we set is 8 to 10 ml or 6 to 8 ml per kilo, little on the higher side. Whereas in baby lung, you may have to give as low as 3 to 4 ml per kilo of tidal volume. That's all it's accommodated like a baby's. So, and there is a lot of heterogeneous lung. It's not homogeneous lung. It's a heterogeneous lung. So there could be stress and strain because of the mechanical ventilation itself, and these lungs are less recruitable. So you need to remember, we are going to discuss all this terminology, something called driving pressure, the PEEP and the flow. So remember, when you are ventilating ARDS lung, you have to do lung protective ventilation strategy and avoid ventilation-induced lung injury. So what are the goals? We are going to improve oxygenation and prevent further damage and causing villi. So the issues here, so these children or the ARDS patients will have low compliance. Remember, the compliance very, very bad. The lungs are too small and decreased time constant. Okay. And it's a heterogeneous lung. There is VQ mismatch and there is increased dead space and there is something called intrapulmonary shunting. It's not in the cardiac shunting. In the lungs itself, there can be shunting. So secondary to widespread atelectasis. So this is what CT scan, which is done in an early ARDS, is of course is an adult picture, just to give a pictorial representation of how these lungs are badly affected. So this is the upper part and this is the dorsal aspect. As you can see, the upper part is relatively spared, normally aerated. The pulmonary edema and the lower part is very badly affected. This is also the lungs or the amount of lungs which are there to ventilate is only this part, the normal lungs part, right? So the lungs, and it is also been compared to as sponge lungs. So the ARDS has got a normal unaerated lungs, right? Normal and unaerated, partially aerated alveoli. So what happens when you ventilate such a lungs? So if this is normal lungs, when you aerate or when you give PPE, it can get hyperinflated. Whereas those lungs which are collapsed lungs, atelectated lungs, hardly, it's very difficult to ventilate. So on one hand, you will be hyperventilating the normal lungs and you may not be ventilating the unaerated lungs. So one has to choose a very careful settings in such a patient. So if you hyperventilate the normal lungs, you can cause ventilator-induced lung injury. That this is a non-dependent bulla, probably due to alveolar overdistension. So lung protective and in these patients, they can have this disappeared. So in these patients, make sure you minimize the lung stress and strain by avoiding the breath stacking dysynchrony and not doing lot of high tidal volume. and as well as high PEEP or low PEEP. All this can cause villi. At the same time, this is called self-inflicted lung injury due to patient's effort. Or a spontaneous infected lung injury. Suppose if you ventilate them very late, or if you do mechanical ventilation in the late form stage of disease, that also can be injurious to such patients, where they can have eccentric injury, longitudinal atrophy, the diaphragm can get a diffuse atrophy because of excessive assist, or if you ventilate them with a low effort drive. So you have to have a tight balance to give LPV, lung protective strategy, not only LPV, lung and diaphragmatic protective strategies, and optimize the diaphragmatic effort and synchrony and avoid villi. So coming to tidal volume in ARDS. So how much tidal volume should we set in? So this is a landmark study by Arts Network published in 2000, where they had, it was an RCT. So 400 patients, this is an adult patient. So most of the studies have been extrapolated from the adult literature. In the one arm, they have used 6 ml per kilo of tidal volume versus traditionally like 10 to 12 ml per kilo of tidal volume. As you can see, the patient where they had a low tidal volume had a mortality of 31% versus nearly 40% with a high tidal volume. The low tidal volume group had high mechanical ventilation free days. So definitely the low tidal volume was productive. And this is a systematic meta-analysis again indicating that mortality at the end of follow-up period of each trial revealed that the mortality benefit was very much good when they ventilated with a low tidal volume. So from then onwards, we have been using low tidal volume as low as 6 ml per kilo, not lesser than 4 ml per kilo tidal volume as compared to 12 ml per kilo. So what does PALIC 2 recommends? Okay, so PALIC is the pediatric international guidelines for diagnosis and management of ARDS. So it recommends 6 to 8 ml per kilo of ideal body weight is what we have to use when of tidal volume per kilo. Suppose if a patient is around 2 years and weighing around 10 kilos, so you may have to give as low as 60 ml per kilo tidal volume of the patient body weight. And always use the PEEP plat and driving pressure to monitor this the tidal volume. So, and you can go as low as 4 ml per kilo to keep the PEEP plateau pressure less than 28. So, this is what the recommendation by PALIC guidelines. So, next we'll move on to the PEEP. How much PEEP should we use in the ARDS? So, setting a PEEP, which or optimal PEEP is that one which gives good compliance and takes care of the CO2 or doesn't worsen CO2, improves the oxygenation, at the same time does not cause hemodynamic effects. So we know that positive pressure ventilation, when we give too much of PEEP, the preload is decreased. Once the venous return or a preload is decreased, the cardiac output suffers. And as a result, these children can develop hemodynamic instability. So we need, whenever we are setting optimal PEEP or PEEP, one should take care of this hemodynamic or this can cause hemodynamic side effects. So we should take care. We are not giving over PEEPing such patients. And the PEEP that cause least driving pressure. All these concepts we will discuss down the line. Remember, setting a PEEP which achieves good compliance and good gas exchange. So PEEP, when we are setting, one can use the ventilatory graphics. This is the PV loop. Remember, we had discussed about the PV loop in the last couple of classes. So there is something called low inflection point and upper inflection point. So this is the lower inflection point. This is the inflation and this is the exhalation. Inhalation limb and the exhalation limb. So if we set the PEEP beyond the LIP, this is where the alveolar will start opening up. The collapsed alveoli, which is what I'm talking about. So the alveolar which are collapsed will start opening up. So between the LIP and UIP, you can see many alveolar which are present in the dorsal lungs will start opening up beyond UIP. You can see here it is hyperinflated, right? So one need to set the PEEP between the safe zone. So that is between the LIP and UIP. But of course, these are the static images, right? So the PEEP, the function of PEEP, again, significant recruitable lung volume. Okay, so opens up the alveoli. Make sure we don't hyperinflate the lung. So, but for all of this, we need to identify which are those ARDS or potentially recruitable ARDS lungs become important. So how much PEEP to set in? Again, what does the evidence say? This is again by ARDS network where they've compared high versus low PEEP. They had a calendar of high PEEP and low PEEP, and the FiO2 they kept on titrating. In low PEEP they started with high and they slowly titrated up to 14, 18 and 20. And the FiO2 from 30%, 40% like that, they went on increasing the FiO2. Whereas in other group, high PEEP, they straight away started with 14 and increased to 22 to 24. And the FiO2 was the same. But when they looked at the analysis, there was no difference between the low PEEP or the high PEEP, the survival or the mortality. So you remember that in ARDS, you can keep low PEEP or high PEEP, but you need to monitor the LIP or the UIP and see whether there is beaking. So, and basically one need to understand that why do we use PEEP? So that this is a heterogeneous lung which is happening in ARDS. You can see the alveolus. These are the normal alveoli. These are hyperinflated alveoli because of the excessive pressure. And this is the dorsal alveoli which is not at all opened up. So by using PEEP, we are homogenizing the lung. So trying to, the middle part at least, trying to inflate the lung, at least the dorsal part to be expanding. So that's what we are trying to do PEEP. Trying to use PEEP to increase the making homogeneous. So this again, we always look at the PALIC guidelines. So the guideline says, so the PEEP should be titrated based on the oxygenation, hemodynamics and the compliance. While doing that, monitor for the intrinsic PEEP flow and pressure time scalar. So level should be at or above the ARDS network low FiO2 table. So they recommend to use low PEEP, that is low PEEP. You remember the low PEEP and high PEEP. So this is the table which is published in the ARDS net. So you can start with the low PEEP FiO2 table. This is called low PEEP FiO2 table. It's good to have this printout stuck in your ICU when you are monitoring or when you are ventilating the ARDS patient. So the PEEP to guide PEEP setting using incremental steps in the FiO2 and PEEP to maintain the PaO2 of 55 to 100. Okay. So this is what happens. This is the normal PV loop. And this is when compliance is affected. What happens? The PV loop will be almost flattened. It will be touching the pressure. So once you give PEEP, so the lung PV loop has become very well erect and expanded. Okay, so how do you set? So you can start off with 5, slowly increase 1 to 2 at a time. And you check the oxygenation, see whether the oxygenation is becoming better. Monitor oxygenation may not be a PaO2s or checking the blood gas. You can look at the monitor, see whether your SpO2 is better, and have a monitor on the P plateau or plateau pressure. We'll discuss in the slides. So it should not be more than 28. So avoid increasing the P plateau. Once you increase the pressure, the plateau pressure also increases. So you should not be, you should be monitoring the plateau pressure. Okay, so and hemodynamics. Other thing is hemodynamics. So as I said earlier, the excessive positive pressure ventilation can cause decreased cardiac output and they can have hypotension. So how do we know optimal PEEP? Optimal PEEP is that one which has got best oxygenation, improves the compliance, does not worsen the carbon dioxide, and with the least hemodynamic side effect. When we are doing this, what are we going to check on the ventilation? We are going to ventilator. We are going to look at the plateau pressure. So the plateau pressure should not exceed 28. Okay. So we will talk about the plateau pressure now. So what is this plateau pressure? Plateau pressure. Plateau means here. So when there is no flow, the pressure. See, this you remember, right? This is your pressure time scalar. Airway pressure and the Tagen's time. So when we give PEEP, your pressure will start increasing from here. This is your peak inspiratory pressure. And when there is no flow, suppose in a volume and control ventilation, when you do inspiratory hold for few seconds, so you will achieve no flow state. Okay. So when there is no flow state, sorry. Yeah. So this is the no flow state. In a volume control ventilation, inspiratory pause for 2 to 3 seconds, you will get something called plateau pressure. The pressure when there is zero flow. Okay. So whereas what about in pressure control ventilation? Pressure control ventilation at the end of the peak inspiratory pressure, at the end of inspiration, whatever pressure you get, that is your plateau pressure. Plateau pressure becomes very, very important when you are ventilating ARDS patient, because one need to monitor the plateau pressure. How much plateau pressure? So once you do this inspiratory hold on a volume control ventilation, you will get that number as PE plats. So how much we have to monitor or how much we have to keep it? So it should be less than 28 centimeters of water. Okay, remember that. But suppose if you are dealing with a nephrotic syndrome or chest in some condition where the chest wall rigidity is there, so in such patient, you can go up your plateau pressure up to 32. But more or less in all the patient with ARDS, one have to monitor the plateau pressure and you have to keep less than 28 centimeters of water. Okay, next concept what we are going to discuss is the driving pressure. So what is this driving pressure? So driving pressure is nothing but difference of P plat minus PP. So we have calculated the P plat, right? So and there we are going to give some PEEP. So that difference between the P plat and PEEP. So what is this driving pressure? So when there is respiratory system is not at all, when the effort of the respiratory system is taken away, the pressure required over and above the P to generate the tidal volume. Okay. So remember, plateau pressure is what you check by doing the inspiratory hold on a volume control or in a pressure control. At the end inspiration, the PIP, the peak inspiratory pressure, is equates to plateau pressure. That we have got. Then you calculate something called driving pressure, which is P plat minus PEC. Why we need to calculate this pressure or we need to monitor? Because it almost correlation of the global lung strain. So how much driving pressure is acceptable? Anything between 13 to 15 is acceptable. So remember this, whenever you are ventilating ARDS, some of these numbers or these pressure one need to monitor. So P plat less than 28 and driving pressure less than 15. So how much ever PEEP you set in, if it is P plat is less than 28 or the driving pressure less than 15, so the patient or the lung is in a safe zone. So regarding any literature review or recent evidence, this is a patient level analysis of 9 RCTs by Meto et al. And what they concluded was, they did lot of permutation and combination where they fix the P plat or they increase the PEP. So, but what they observed was elevated driving pressure appears to be correlated with mortality. So anything driving pressure more than 15, the mortality was pretty higher. So they concluded that keep the driving pressure less than 15 centimeter of water. So Palik took that reference and incorporated this research, and they recommended to keep the driving pressure less than 15 centimeter of water. Okay, so this is some sort of algorithm flow for lung protective ventilation based on the driving pressure. So to start with, you're going to set the tidal volume at 6 to 8 ml per kilo of ideal body weight tidal volume. You check the driving pressure. Of course, you're going to set the PEEP looking at the low PEEP FiO2 table, right? And rates can be little higher side. And then while and to start with 100% FiO2 and slowly you come down to 50 or 60%. While doing all of this, you're going to check the PEEP plats and you're going to calculate the driving pressure, which is the difference between the PEEP plat and PEP. And if you are keeping less than 15, you are in the safe belt. If it is suppose, if your driving pressure is crossing more than 15 centimeter, that means you have to come down on the tidal volume. The compliance is pretty bad. These lungs are pretty stiff. So you might be setting high pressure. So decrease the tidal volume and probably consider proning to bring this driving pressure less than 50. Or sometimes when you are unable to do all this, one can consider to oscillate this patient. That means you can attach them to high frequency oscillatory ventilation. Suppose your driving pressure is decreased, there's decreased CRS, you may have to consider other restrictive disease. Very rarely we do see a condition like restrictive lung disease, but this is what you're supposed to follow. Okay, so to keep driving pressure less than 15. So in the ARDS, you need to understand the disease as well as the machine. So in disease, we have spoken so much about volume loss, baby lung, heterogeneous lung, and decreased FRC, atelectatic alveoli. And if we don't do wise ventilation, the ventilator-induced lung injury becomes a concern. So what are we supposed to do? We have to set low tidal volume, 6 to 8 ml per kilo of idle body weight, PEEP, moderate to high PEEP. Optimal PEEP is what we recommended, just to open up the alveoli and keep it open. And FiO2, not non-toxic FiO2, that is, don't keep 100% all the time. Try to come less than 60% to avoid biotrauma, and limit your plateau pressure. So the strategies, again, remember this golden rules for ARDS when you are ventilating ARDS. This is ARDS trial strategies. A low tidal volume, optimal PEEP, plateau pressure less than 28. While doing all of this, the CO2s can increase. That is the problem with when we are ventilating low tidal volume. But if the pH is okay, the pH is more than 7.2 and there is no raised ICP, or you're not dealing a child with cerebral edema, you can very well accept high CO2 provided if pH is more than 7.2. Non-toxic FiO2, as I said earlier. So do not ventilate or do not keep 100% FiO2. Try to decrease to less than 60% and limit your driving pressure less than 50. So which mode to use? You can choose either pressure control or a volume to whichever you are comfortable. There is no head-to-head trial to say any of this mode is superior over the other. So to begin with, if you are choosing pressure control, so PIP set at 15, look for the chest rise, you may have to go to 15 to 18. PEP, follow the lower PEP FiO2 table, start at 5 to 7. And to begin with FiO2 100% and slowly titrate to 60%, i.e. ratio 1.2. Physiological rates, not to begin with, later on look at the CO2. But when you set the pressure control, check the volume. Okay. So likewise, when you do the volume control, you can have a tight control of the volume. You can straight away check the, set at 6 ml per kilo of predicted body weight. The other strategies remain the same. Check the pressure, as this can lead to barotrauma. Okay, so yes. So use the familiar mode. There is no more superior mode for ARDS. Basically, pressure mode is usually selected for better gas distribution because of the decelerating flow. If you remember that in the previous class, we spoke that pressure mode has got decelerating flow, which is quite beneficial in ARDS. Suppose if the patient, even after doing all this maximal ventilative setting, child doesn't improve, one can consider proning ventilation. So proning has got its own mechanism. So basically, when the patient with ARDS is prone, what happens? Normally, the heart and the mediastinal structures will be compressing the dorsal part, and which will not allow for the dorsal part to expand, as well as the abdominal and the caudal diaphragm can act as a pincers. So once you're prone, all this, the effects is released. So as a result, the dorsal part gets better aerated. So this is just a pictorial diagram. This is in supine position and this is in the prone position. As you can see, hardly any lungs are getting ventilated or aerated. But when you prone these patients, you can see that this is the dorsal part is getting little bit aerated. The entire the mediastinum and defect of the mediastinum and the heart is taken away. And there can be uniform VQ matching. Okay, so in ARDS, one of the pathophysiologies, they have mismatch of the ventilation and perfusion. So while doing prone position, the VQ mismatch decreases. As a result, the oxygenation improves. And the chest compliance also, the supine position, the mobile anterior chest wall allows preferential ventilation. Whereas in prone position, the restriction of the anterior chest wall is almost taken away, making it homogeneous. Remember in ARDS, as I said, you should push them to homogeneity. The lungs are all heterogeneous, so we may have to make it homogeneous by doing all these strategies. So again, what about evidence? This is the literature on prone position. This is published in 2013. So again, the RCT, this is an adult study, RCT was done. So they included patient less than 150, sorry, the PF ratio less than 150. They were randomized into prone and supine group. Prone was considered for more than 16 hours after these patients fulfilled the criteria of ARDS and they were severely hypoxemic. that is PF less than 150, and they compared the mortality. As you can see, the mortality in the prone position was very, very less. It's almost 16% versus 32%. There were better survives in the prone group. So they concluded that early prolonged period of proning in ARDS with PF less than 150 can lead to prolonged ventilation free days and reduces the mortality. So yeah, what about PALIC 2? What do they recommend? They say insufficient data to support or refute the use of prone position, but one can consider proning in patients who are hypoxemic and not responding to your conventional strategies. What are the conventional strategies? Again, that 6 to 8 ml per kilo body weight, appropriate PEEP or optimal PEEP, IE ratio. So after and FiO2, suppose with all of this, if the patient hypoxemia is not improving, one can consider proning. So in a nutshell, when you are ventilating ARDS lung, remember this rule of 10. Tidal volume 6 to 8 ml per kilo of ideal body weight. Monitor PEEP plant less than 28. Simultaneously look at the driving pressure less than 15. Respiratory rate, it should be physiological respiratory rate. This is an adult recommendation. You can ignore this. PEEP, avoid keeping high PEEP. Use personalized PEEP. Some children might benefit with 10 PEEP, another child might require higher PEEP. So personalized PEEP at the same time, or optimal PEEP, which has got good oxygenation, good carbon dioxide, and with least hemodynamic instability. If you can get an opportunity to calculate mechanical power, one can do that. Early proning is recommended up to 16 hours if PF is less than 150. Use wisely the neuromuscular blockades and recruitment maneuver. I'm not going to deal with the RMs. That itself is a big chapter altogether. And ECMO. Lastly, if none of this works, use ECMO. This is what the golden rules when you're treating with ARDS. So now we'll move on to severe airway obstruction. That is your bronchial asthma. Nitin, should I pause here or should I move on?
Ma'am, continue.
Okay. So because these two are entirely, two different ventilation strategies, I just want you people to understand. Remember this: ARDS, low tidal volume. Some of this pressures you need to monitor, like your PEEP plant and driving pressure you have to calculate. PEEP, optimal PEEP, early proning. Okay. So this is what. So having understood this, we'll move on to bronchial asthma. Okay. So in bronchial asthma, we'll come back to the same, the resistance and compliance, right? So this, I am sure you must have, all of you would have treated patient with bronchial asthma. Very rarely one ventilates or these children will require mechanical ventilation. So what is the pathophysiology? What is the underlying? We know that in bronchial asthma, the compliance is good, in fact, right? So compliance is good. Lungs, alveolus are in fact hyper-aerated, but there is a problem with the resistance. That is the airway related problem. Okay. So there is increased resistance, increased time constant, and exhalation is what is prolonged or affected. Commonest example, it could be your bronchial asthma or children with bronchiolitis. Okay. So this is a scenario. This is a 15-month-old child with history of fever, 10 days, cough. He was the last 10 days, cough the last 6 days, and he presented to the ER with fast breathing. And this is what is X-ray. This is how he's breathing. This is the 15-month and this is the X-ray. X-ray looks hyperinflated, definitely for sure. Some streaky infiltrates are present. And he's received back-to-back salbutamol nebulization. Steroids have been administered. Still, he continues to be tachypneic, right? So that's what. So on examination, the heart rate is 170. The hemodynamic looks perfect, but he seems to be tachypneic, and he's got severe subcostal and intercostal retraction. We have given back-to-back nebulization, and he's got bilateral V's. His diagnosis is reactive airway disease, acute exacerbation of bronchial. I mean, we don't label as bronchial asthma in under 5. So V's associate lower tract infection, right? So when you get such a child, first always, classify them. You have to give continuous back-to-back nebulization with your salbutamol. If in case, if it's a bigger children who is a known wheezer, one can do MDI spacer every 4 to 10 puffs every 20 minutes and start steroid, start oxygen and classify them whether there is mild, moderate, or severe or a life threatening. This is the GINA recommendation. I'm sure all of you must be familiar with this. Suppose if he is not improving with the bronchodilators or steroids, then you may have find is becoming very drowsy and chest is becoming silent. These are the children who will require high intensive care unit or high dependency unit. So how do we manage such a child? Of course, the bronchodilators are the choice of treatment in when you're treating the child with lower airway obstruction. And if it's bronchiolitis, you can just do plain nebulization or a plain saline nebulization. And we have to consider early respiratory support in the form of HHFNC, that is high flow humidified oxygen phase nasal cannula, high flow nasal cannula, or sometimes NIV in a bigger children. IMV will reserve it for only a specific group of patients. So remember, respiratory support should be as far as possible non-invasive respiratory support, either HFNC or NIV in a bigger patient. And simultaneously, you have to continue your bronchodilators like salbutamol, ipravent to be continued. Steroids, of course, you would have used. Magnesium sulfate you can use. Rarely these children will require antibiotics if they are hypoxemic, and draw some of the routine labs. So before we move on to mechanical ventilation, one need to understand the lung mechanics and what are the problem in case of lower airway obstruction. So we know that in bronchial asthma, the main problem is expiratory flow limitation. That is, exhalation is getting affected because the inspiratory muscle will become active even before the exhalation gets completed. As a result, there is air trapping, which also called dynamic hyperinflation. So this results in intrinsic PEEP or worsening or auto PEEP. Your elastic recoil of the lung is decreased, whereas the chest elastic recoil is increased, and there is increased loading of the inspiratory muscle, and there is inspiratory muscle dysfunction. All this results in tachypnea. Child can become extremely tachypneic, and your PO2 in the late stage, the PO2 gets affected, then the PCO2 will start building up with decrease in the pH. All this will result into abnormal gas exchange or worsening of the dead space. There is neuromechanical uncoupling, and at the later stage, if you don't take care of dynamic hyperinflation, this can result into hemodynamic compromise or cardiovascular effect. Again, what is that? That PPV, the preload will decrease, the LV afterload will increase, and cardiac output falls. So this is the pathophysiology in a severe bronchial lower airway obstruction. So remember, the dynamic hyperinflation, they have got very high auto PEEP and they have got high respiratory rates. If you don't treat them, they can go into hemodynamic compromise. So when should we consider positive pressure ventilation? Is it a friend or is it an enemy? So it's age-old teaching is said that we should be very, very careful when we are ventilating or considering ventilation in bronchial asthma. So these are the pathophysiology, right? We discussed all this. Dynamic hyperinflation is there. The inspiratory threshold loading will be very high. So PPV can reduce the loading and decreases the expiratory flow limitation. Can improve VQ mismatching hypoxemia. But if you ventilate these patients, you may have to sedate them, paralyze them, because there will be a lot of asynchrony. And their pressure, because of the dynamic hyperinflation, their pressure will be very requirement, may not be high, but the pressure already which is there, like auto PEEP can worsen, and there will these children are at risk for barotrauma and polytrauma and cardiac effect. So ventilation in ARDS, asthma, one has to be very, very careful. So you can consider non-invasive ventilation or HFNC in the lower airway obstruction, especially in mild, moderate, even in the severe stages. And of course, it has got its own principles of NIVs. It prevents the airway collapse, unloads the respiratory muscles, and reduces the work of breathing. At the same time, it improves the alveolar ventilation. But you should be, there are certain prerequisites like the patient selection. Patient should not, the sensorium should be good. The child should not be unconscious, and you need to use appropriate size, mask, and interface. So remember, NIV is useful even in the early part of ARDS. NIV is pretty useful, but if your unit is experienced in using non-invasive ventilation, one can use NIV, whether it's ARDS and asthma in the early stages. but it's a labor intensive. Your nurses, you should be trained and you should be tuned to the NIV setting and should know certain contraindication like depressed sensorium, if airway lip reflexes are lost in such patient or hemodynamic instability. So you should be avoiding NIV. So when should we intubate in a child with bronchial asthma? No, so bronchial asthma, as I said, avoid intubation as late as possible unless the patient has got deteriorating mental status. He's becoming, sensorium is becoming depressed or is becoming completely exhausted or severe hypoxemia. Okay, so that are going, or the patient might be going to impending respiratory arrest. So in those conditions, only you will consider invasive mechanical ventilation. So in bronchial asthma, avoid PPV. Okay, so as far as possible, non-invasive or HFNC works well, and along with your bronchodilator treatment. So when you're considering intubation in bronchial asthma, so clinical judgment becomes very, very important. Rapid progression can occur and timely intubation can save these patients. And remember, decision should not be just based on the blood gas values. It's mainly clinical judgment. So one need to practice safe intubation in patient with bronchial asthma, bronchiolitis, because these children at the act of intubation itself, they can develop arrest or they can go into arrest. So pre-oxygenate pretty well, give appropriate, you can start off with fluid bolus, minimize bag and mask ventilation, because while doing bag and mask ventilation, you might be giving high tidal volume. So dynamic hyperinflation can get worse. Volume trauma, barotrauma can be at high risk. So use certain drugs which causes bronchodilators like ketamine. Okay, avoid certain drugs which causes bronchoconstriction like atracuronium, and also you can use paralytics like vecuronium. And intubation should always be a senior person or by expert. Okay, so remember, whenever you're going to intubate bronchial asthma, you follow certain steps and use medications which cause bronchodilators. The goal of mechanical ventilation in such a patient is minimize air trapping or dynamic hyperinflation, increase the alveolar ventilation and improve gas exchange. And it same thing holds good whether you're treating ARDS or bronchial asthma, you should avoid ventilation-induced lung injury by decrease using less tidal volume or less pressures. Okay, these are the goals. How do you achieve these goals? To correct hypoxemia, you're not going to worsen the dynamic hyperinflation. These are the strategies. So what do? You use low ventilatory rates to allow very long exhalation time. Okay. Suppose if you are ventilating a 2-year-old child, normally you might set a respiratory rate around some 30. But when if it is ARDS, 30 is good. But if it is bronchial asthma, you may have to go as low as 20. Okay, so and you have to allow for long exhalation time, right? And then what about tidal volume? Again, 6 to 8 or 5 to 7 ml per kilo, but you will have a watch on the plateau pressure, right? Thirdly, what is the problem when you're using low tidal volume, low rate? Your CO2 buildup happens. So, but if the pH is more than 7.2, you can accept CO2 up to 50, 60. Okay, will not be chasing the CO2 unless the child has got brain or raised ICP thing. So don't worry about the CO2. Other thing one need to monitor is the P flat. Here you can go up to 35. You can accept up to 35 centimeter. Unlike in ARDS, one has to monitor less than 28. But in bronchial asthma, it is 35 centimeter. And how much PEEP to set in? So in bronchial asthma, there is dynamic hyperinflation because of presence of auto PEEP. So that means some amount of PEEP is required. It helps to unload the respiratory muscles and easy triggering on the ventilator. But your PEEP, whatever you set in, should be 2/3 of the auto PEEP. So you need to measure or check the auto PEEP. How do one check auto PEEP? You have to use the expiratory expiratory hold for 2 to 3 seconds, and the auto PEEP get displayed on the ventilator. Suppose if your auto PEEP is around 8 or 9, so you may have to set around 4 to 5 PEEP. But 0 PEEP is not acceptable. That will again increase the work of breathing. So remember, when you are setting an auto PEEP in a child with lower area obstruction, it should be 2/3 of the when you're setting a PEEP, extensive PEEP, it should be 2/3 of the auto PEEP. So while doing all of this, the patient can have asynchrony on the ventilator. One may have to take care of adequate sedation and analgesia to overcome the spontaneous respiratory effects. So recommended initial ventilatory setting, any mode, whichever you are familiar with. Okay. So adequate tidal volume, because don't keep too low, 4 ml per kilo, because the CO2 will be very high. You can start with 6 to 7 ml and optimize your tidal volume. Low rates, I ratio, you can increase from 1 to 2 to 1:3. PEEP, that is 2/3 of auto PEEP. PEEP plant around 30 to 35 centimeter of water. Accept permissive hypercapnia, and oxygenation can be more than 90 to 92%. You have to limit your FiO2. So causes of auto PEEP, whenever we talk about lower obstruction, we will be always talking about this auto PEEP, and extrinsic PEEP is good. The causes why this auto PEEP develop this, there is dynamic airway collapse, deceleration of expiratory flow. How do you detect this? Is like the expiratory flow, your ETCO2 will show sharp in appearance. I have some slides that show you that. And because of the auto PEEP, there is increased inspiratory muscle activity and increased ventilation, there will be asynchrony. So the PEEP, zero PEEP is harmful in bronchial asthma. Some amount of PEEP is required for alveolar recruitment and improves oxygenation and decreases atelectatic trauma. If you use zero PEEP, the dynamic hyperinflation can be reduced, but there will be adverse effect of all these hyperinflation can reduce, but there will be increased increased work of breathing. So nobody recommends zero PEEP when you are doing and you are ventilating bronchial asthma. Some amount of extensive PEEP should be set in. So conclusion, so during controlled ventilation, no benefit from PEEP regarding work of breathing since patients are passive. But when your patients start breathing actively, right, extrinsic PEEP is used in subset of patients with auto PEEP who have low limitation, and low levels of PEEP especially used at the resolution phase of the disease. So as I said earlier, 2/3 of the auto PEEP, you need to check the auto PEEP. That's what is the recommended PEEP. So how do you monitor dynamic hyperinflation? So clinically, always see that whether the breath sounds are decreased or improved. Increased inspiratory effort to trigger the ventilation or increased tidal volume. In X-rays, you'll see hyperinflated lung fields. And your ventilatory graphics will give a picture of this auto PEEP or dynamic hyperinflation. As you can see, this is your flow volume curve. You can see that inspiratory is not touching the baseline. Can you see this? This is the inspiratory not touching the baseline. Then that's when we can say there is an auto PEEP, and there is progressively increasing the PEP or intrinsic PEEP. So that is what the one your graphics can give an idea of whether there is an auto PEEP or dynamic hyperinflation. Flow volume loop also you can see in the inspiratory and the expiratory flow, it is not returning to the baseline. So, and the resistance, when there is high resistance, there can be scooped out appearance in the exhalation loop. So capnography also can give a picture about your auto PEEP. So you can, this is a normal capnography, the square waveform, whereas in asthmatic it is sharp in appearance. So one of the very important practical points for ventilating asthmatic is use non-invasive or HHFNC. It's a very good option if there is increased work of breathing and impending respiratory failure. And once you ventilate, these children can develop hypotension because of decreased cardiac output. So beware of these effects. PAP estimate the degree of bronchospasm, but the broader trauma you can monitor depending on the PEEP plat, and never forget to continue the medical management of asthma like bronchodilators, steroids, magnesium sulfates, and avoid using muscular relaxants, paralytics, because these children will be at risk for critical illness, myopathy. Very importantly, fast track weaning. That is, you should be taking these children out of ventilator as soon as possible, wean them as quickly as possible. So we have discussed all about ARDS, ventilating strategies of ARDS, and how contrast the ventilating strategy of when you're ventilating a lower airway obstruction. So you have to remember certain figures. You should know the guidelines and understand the lung mechanics. Okay. So as I said earlier, ventilation is just a support, but it's never cured. You have to treat the patient, use all the other monitoring effects. Yeah, all the other. I think there is a video which is not there. Monitoring effects. Thank you. And that is cardiac disease. We will deal or we will talk in the next class. Thank you so much for your patient listening. I think this is just a video. So remember to support the lungs and avoid ventilation-induced lung injury. Thank you so much for your patient listening. Dr. Nitin, I finished my talk.
Ma'am, can we take questions?
Okay, okay.
There is one, ma'am. Delta P and P flat not shown on ventilator. When to decide to do the inspiratory hold?
See, when to decide to do the inspiratory. See, if you are dealing with a heterogeneous lung and you know that, these pressures one need to monitor. P flat is, and delta P is not shown. P flat is something which you measure by doing an inspiratory hold. See, for all normal lungs, you don't have to do this measurement of P flat or driving pressure, calculate driving pressure. But when you are dealing with the patient with ARDS, once they fulfill the PALIC criteria, whether it could be mild, moderate, or severe. So you have to monitor these parameters. So P flat by doing inspiratory hold on a volume control. So you will get for inspiratory hold do for 2 to 3 seconds and the P flat get displayed on the ventilator. Driving pressure. So once you calculate the P flat, that you have to subtract it from PEP, positive end expiratory pressure. That's what gives the driving pressure. This is in patients with ARDS patients. Okay, so one have to have a close monitoring of delta P and P flat. So no volume like that. How do we do bronchodilator treatment? Yeah, so HFNC, whenever you are doing bronchodilator treatment, see there are two options. One is HFNC, the regular HFNC. When you want to do bronchodilator therapy, you have to reduce the flow. See, in HFNC, you are giving high flow, 1 to 2 liters per kg per minute, isn't it? So you reduce the flow. Suppose if a child is 2 kilos and weighing 2 years weighing 10 kilos, you would have said 20 liters. So reduce that flow to 5 liters or 8 liters, and you can give with face mask, regular bronchodilator nebulization mask. There is another thing is you in the HFNC you get a separate knob where you can connect through the HFNC circuit, and that delivers the it's like a jet nebulizer or so, which is a separate accessory altogether. You can connect to the regular HFNC circuit and you can give bronchodilator therapy. Dynamic compliance role in AR. Dynamic compliance. See, we are okay. See, understand compliance is affected. Okay, ARDS is a condition of low compliance. Okay, so there is something called static compliance and dynamic. These are all the terminologies. So when you're treating a patient with ARDS, you one need to monitor the P based on the compliance. In the monitor, on the ventilatory screen, you will get something called dynamic compliance. If you go to the second or third page, one can monitor that compliance and titrate your P. Okay, so that is whatever is displayed is the dynamic compliance. Okay, so but clinically, look at people talk about the plateau pressure and driving pressure. Only while titrating the PEEP, you can regularly check the dynamic compliance, or in daily, like suppose these children are getting ventilated and daily you can look at that monitor and see whether the compliance is improving or the numbers are getting better. So on severe ARDS, when to so actually I skipped the slide on non-invasive ventilation in early ARDS. Again, non-invasive ventilation in ARDS per se, PALIC 2 recommends that in early ARDS, when the patient has got mild ARDS, okay, OI is around less than 4 or OSI, oxygenation saturation index is less than 6. You can not OIs, but your PF ratios are less than 300, you can consider non-invasive ventilation. And that is only for early ARDS, but at the same time, you should have a low threshold for intubating ARDS patient, because ARDS is a progressive disease, right? Once you attach to a non-invasive ventilation, you should regularly monitor their RDS, their SpO2 monitoring should happen. or SF ratio should be monitored, clinical improvement or not, okay, and low threshold for intubation. Within 4 to 6 hours, if the patient is improving, obviously the respiratory distress, the RDS score can become better, the hemodynamics can become better. Suppose at the end of 4 hours or 6 hours, the patient continues to be tachypnic, saturation still 90, borderline 89 or 90. The PCLI, that is patient spontaneous, breathing injury, self-inflicted lung injury or spontaneous CLI component is high, that can further worsen the inflammatory cascade. So you may have to consider early intubation. How much dynamic compliance indicate that lungs are bad? See, dynamic compliance, of course, in the adults, it's 30 to 50 ml per centimeter of water. In children, in small children, sometimes even 5 ml, 6 ml. There is, based on that number, nobody has studied this, how much dynamic compliance indicates bad. It's a serial dynamic. So in the children, they say 1 ml per centimeter per kilo, 3 to 5 ml per centimeter per kilo, like that. So you look at the clinical picture and you will know once you're bagging or with the patient is requiring high pressure, that means the compliance is pretty bad. Usually change respiratory rate based on the PCO2, when to go for I ratio change and which is better. So this again depends on you're dealing with ARDS or bronchial asthma. So in ARDS, the respiratory rate, if you're talking about ARDS, you can accept high PCO2 provided pH is more than 7.2 and child does not have raised ICP. Okay, so there 1:2 you use to begin with, but in severe hypoxemia, you can do 1:1. Suppose if you are ventilating a patient with bronchiolitis or a bronchial asthma, okay, and you are using low respiratory rate, obviously the CO2 will be on the higher side, but you have to simultaneously, you don't have to wait for anything, you can set prolonged E time. So instead of 1:2, you can straight away start up with 1:3. What is that? I don't know, is there a specific number of come to say the same thing again, dynamic compliance, and there is nothing specific number. Auto PEEP in severe bronchospasm. Please give overview of managing is an emergency. So circulate, that means this patient's circulatory collapse means this patient can develop cardiac arrest as well. So this is in a condition where the patient has got severe expiratory airflow limitation. As a result, there is a dynamic hyperinflation, and that can have an effect on the cardiac, right? So what you're supposed to do in such a patient, one is the severe dynamic hyperinflation, second is pneumothorax. These are the two conditions which can lead to circulatory collapse. You have to immediately rule out this. Okay, so again, clinical bilateral air entry, you check. In both, you can have silent chest, both in severe DHA as well as tension or pneumothorax, isn't it? So both you can have, you have to, disconnect from the ventilator, start bagging, don't bag at the high rates, slow rates. Okay, one, you can use bedside ultrasound to rule out to your pneumothorax. Thirdly, you can deflate the cuff and allow the CO2 to release or exhalation, whatever the air trapping to release. Fourth, you can squeeze the chest and you can really or remove that accumulated auto air trapping. Okay, so these are certain things. And suppose you strongly feel, despite all this, the child is not improving, probably it's a pneumothorax, you may have to put a needle in the mid-clavicular line and decompress the lung or release the tension pneumothorax. Okay, so acute bronchiolitis not improving. What is it? See, acute bronchiolitis again in you consider in small children rather an NIV, HHFNC, your high flow humidified cannula works pretty well. So consider HHFNC in such a children, and they do respond pretty well actually. But some small proportion of children, can go on to mechanical ventilation. Again, the strategies remain similar to ventilating in lower airway obstruction, which I discussed towards the end, that is bronchial asthma. Same thing, low rates, tidal volume 6 to 8 ml per kilo of body weight, prolonged IE ratios, PEEP 2/3 of auto PEEP. Yeah, I think I've answered most of the questions. Thank you, ma'am. Oh, somebody said thank you. Okay, any further questions? I don't see any further questions.
If at all there will be questions, we'll take them on the group. Thank you for such an amazing, elaborate, tiring, and I know I can see you presentation, but I think it is one of the most important aspects of managing pediatric respiratory emergencies, and you have nobody else can do justice more than you, ma'am. Thanks a lot for taking out time from a busy schedule.
Thank you. Thank you so much. Thank you. Bye.
Take care, ma'am. Thank you everyone for joining. Bye bye.